Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Naha Balada from Roots Community Health Center, reporting for the week of February 12th, 2024. Following an update on COVID, flu, and RSV, I will discuss long COVID, exercise, and advocacy. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. COVID is still with us. It's still causing sickness, disability, and death, and there is still a lot we don't know. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Nationally, wastewater viral activity level is high for COVID, and that is down from very high. So that is good news. You can see these 5 lines here. The black line represents the national average, and you can see that most regions are essentially on the downturn. Only the South seems to still have quite high viral activity in the wastewater, although hopefully it looks like it may be coming down as well, but still considerably higher than the rest of the nation. Taking a look at weekly new hospital COVID admissions, these do continue to come down. We're at 20,772 hospital admissions for or with COVID the week ending February 3rd. And this is now the 4th week in a row that hospitalizations are coming down. So let us hope that that trend continues. Taking a look at deaths, unfortunately, this continues to go up. For the week ending January 13th, we had at least 2,318 deaths in the United States due to COVID. And this is up from 2,278 deaths the week before. So this is the 7th week in a row that deaths have been increasing. And we've had over 2,000 deaths per week for several weeks now. This is still way too many people dying from COVID every single week. And we are still waiting to see this peak and come back down, but that has not happened yet. We know that we can prevent a number of these hospitalizations and deaths by reducing the transmission of SARS-CoV-2, also staying up to date on vaccination, and also timely outpatient treatment. So make a plan in advance, and certainly for any of your loved ones who are, especially if they're at risk of a bad outcome, we really want to make sure they're up to date on their vaccine and that they have a plan for outpatient treatment if and when they need it. Now, taking a look at variant proportions, this has not been updated since last week's briefing, so we'll see the update next week, but essentially JN.1 is at 93.1% of specimens. It's really pretty much the main thing that we're dealing with here in the United States. But CDC did announce on February 9th, just a few days ago, that they are tracking and analyzing BA.2.87.1. This is a new variant of SARS-CoV-2, and it has been detected 9 times in South Africa. We have not seen it yet in the United States. Based on the information that we do have, they feel that the public health risk is low. It just doesn't seem to be taking off or out competing the variants that are circulating at this time, but we'll just be keeping an eye on it. I wanted to bring this up because I think this is one of the areas where I feel hopeful that we are doing a fair amount of sequencing and paying attention to what is going on around the world so that we can get ahead of things. And so with just 9 times this variant being detected in South Africa, for the CDC to be monitoring this closely, I think does give some reassurance, but we'll just keep an eye on it. And taking a look at influenza for the week ending February 3rd, we see that it's doing some zigzagging here, so not really too sure which way things will be going. We'll just kind of keep an eye on it. But so far this season, we have had about 250,000 flu hospitalizations, about 15,000 total flu deaths, and unfortunately 74 of those were pediatric deaths. And many of these are preventable as well with the flu vaccine. It's not too late to get that. It's recommended for everyone 6 months and up, and we could be preventing quite a number of these hospitalizations and deaths. And we don't know how much longer flu season is going to be going on, so it's not too late to get your flu vaccine for this season. And taking a look at RSV nationwide, we can see that it was doing quite a bit of zigzagging there, it looks like, for a minute, but it does seem to be coming down nicely. And we are also seeing RSV hospitalizations coming down. So that is certainly good news. If you are in the high risk category for RSV and would be a candidate for the vaccine, there's some new information that I'll go over in a future briefing that looks like the protection from that one is lasting more than just a season. So we'll continue to get more data about that new RSV vaccination, but certainly is not a bad idea if you are in the group that should be receiving it to get it now. Don't think just because we are coming down that we're out of the woods. Still quite a lot of RSV circulating, and it does look like that vaccine may actually give protection through next season as well. So more to come on that. Now I wanted to talk a little bit about long COVID and hit on a couple of topics in particular that have been coming up. So just for overview, we know that some people who have been infected with COVID experience long-term effects of their infection or long COVID. It's still pretty broadly defined as symptoms, signs, conditions that either continue, they persist after the acute COVID infection, or they could even develop a little later, like weeks to a month or two later. And those symptoms or signs or conditions could last for weeks or months or even years. It does occur more often in those who've had severe COVID, but anyone who's been infected with COVID can experience long COVID. And since so many more people who've had COVID didn't have severe illness, the largest group of people who currently have long COVID are actually those who had what would have otherwise been considered a mild acute case of COVID. There is still a lot we don't know about who gets long COVID and why, and whether groups who, whether there are certain groups who are disproportionately impacted. There's just still quite a lot we don't know. But we do know that in at least some subset of people with long COVID, their symptoms can get significantly worse with physical or mental exertion. We know we've all heard a lot about the brain fog, where individuals may have difficulty remembering things or difficulty concentrating on things. We also know that for some people with long COVID, they experience what's called exercise intolerance, or they're unable to perform physical activity at the level that they may have pre-COVID. But even more than that, or even more extreme than that, we know that long COVID has many similarities and overlap with myalgic encephalomyelitis or chronic fatigue syndrome, ME/CFS. And I went into some detail in a prior briefing about this, so that is linked in the post if you want to take a look at that. That's a condition that can occur after a viral or other infection. And so we know there's overlap between long COVID and ME/CFS. We also know that there are some differences. Long COVID seems to encompass many other features that we don't necessarily see with ME/CFS. For example, the loss of taste and smell. And we know that many of the organ manifestations and neurological issues and so on may or may not be seen with ME/CFS. So long COVID is new in the sense that we never saw COVID before, so we never saw long COVID before. It's new, and it does have some features that overlap with other post-viral chronic conditions like ME/CFS. So ideally, we'll be able to do a couple of things. One, improve our understanding of long COVID by drawing upon what we may already know about ME/CFS. And just as importantly, improve our understanding of ME/CFS by accelerating our understanding of long COVID. So this should not be an either or situation, although I understand that this is a very, I think, challenging topic because there are people who have been suffering with ME/CFS for far too long without much attention on their disease. And there feels like a risk that long COVID has now come along and overshadowed the needs of those patients with ME/CFS, and that by focusing primarily on long COVID, while we've acknowledged that there are differences, what will we be missing for patients with ME/CFS? I think that's a very, very real concern. And then I also think that there's a concern that for long COVID patients, that by trying to lump everything into ME/CFS and basically not acknowledge how new long COVID is, that we are going to lack the urgency that is really required to meet this moment. And that is also a very legitimate and real concern. So many things can obviously be true at once. But I would just say, from the standpoint of really being in community health, being a physician, and understanding that we've never ever been able to just focus on one thing. And when we do, we are really shortchanging ourselves and our patients and the overall field. And so I would just want to encourage all of us to not think of this as an either or situation. This should not be a zero-sum game. In fact, I hope that we will be adding, not taking away from any field or any experience out there. Now, having said that, there has been some controversy in one of the features that we see with long COVID and with ME/CFS, and that is called post-exertional malaise. And this is where people actually get worse after physical or mental exertion. And I'll get more into the definition in a moment. But I think what has been the maybe controversy or perhaps misunderstanding or even harmful myths, I'll say, that have emerged is that some people, some patients with long COVID or with ME/CFS have been told that their symptoms are because they're deconditioned. They've gotten out of shape. They weren't physically active when they got sick. Their symptoms persisted. They felt fatigue and malaise, and they're just deconditioned. So if they just got up and started reconditioning, then they would get better. And this is unfortunately harmful in a number of ways. First of all, for some people, this could not be further from the truth, and it can worsen their condition if they actually take this advice. But I think it also puts a bit of a stigma or a bit of a harmful mischaracterization on people who are experiencing this by making it seem as though it is somehow their fault that they're just out of shape and haven't gotten up and moved around. And once again, nothing could be further from the truth. For at least some subset of patients, exercise can actually really set them back considerably. So we all, any of us who know people with long COVID, which at the rate that we're going with over 20 million people experiencing it now, and with so much COVID transmission and so many people catching it every day, unfortunately, I think we're all going to know people with long COVID. And or unfortunately, it's going to touch all of our lives, I should say it like that. Is that I think we all need to get a better understanding of this phenomenon. And certainly those of us who are treating patients, treating people with this, we want to be careful not to give out any harmful advice. So what is post-exertional malaise? So this is worsening of symptoms after physical or mental exertion, which could really be even what we would otherwise consider minor physical or mental exertion. And symptoms usually worsen 12 to 48 hours after the activity, and it can last for days or even weeks. So you can see how even just one time of overexerting oneself could then set that person back for days or even weeks. So it becomes really important to monitor and kind of gauge what activities are going to impact the patient in this way. And it's unfortunately, of course, different for everyone. And one of the things that has been touted quite a bit is what's called pacing, and that just basically means trying to mitigate the activities that you're doing and basically pace yourself with a goal of avoiding any flare ups or any relapses. And so it is a constant balancing act between doing the activities that you need to do or want to do and getting rest. And from all that we are hearing from patients, this isn't a static thing either. So what may be happening now may be different next month. And so it is really a process of staying very in tune with yourself and being very aware of what activities may be setting you back. And I've linked in the post kind of an infographic from the CDC, and it is about ME/CFS specifically, but it's about post-exertional malaise, and it's kind of talking to healthcare providers actually. But I thought it might be helpful to go through it or to at least link it in the post so that you can check it out if it seems like it might be useful. But really, the gist of it is to ask patients to keep a diary for 1 to 2 weeks of symptoms and all of the activities that they're engaged in. And this could be a mental activity, this could be reading, this could be answering emails, and really including all the details possible about the type of activity, the intensity of the activity, how long you were doing the activity, and then basically creating that diary and reviewing that diary just to see if there's any patterns. And so the example that they gave is a patient may find that reading for 30 minutes is fine, but reading for an hour leads to the post-exertional malaise. And so then you kind of set some of those parameters for the patient based upon that. And they really stress brainstorming together. So you, with your doctor and your patient, basically brainstorming together how to adjust activities to avoid or reduce the risk of post-exertional malaise, like maybe setting timers or things of that nature, or considering other ways to get the things accomplished. If it is, doing audiobooks, if it is ordering groceries, if that is possible, and so on. And so this is just something that, I'm saying this understanding that there's still a lot of physicians who are not going to be as knowledgeable about this yet, and also may or may not even have, the time within the appointment to get to all of the things, let alone doing this type of activity. But I'm bringing it up because I think advocating for yourself when you have long COVID, even though it really can feel unfair that a patient who is going through all of this would have to then essentially teach their healthcare providers. But we really are in a situation of the field rapidly evolving, and some of you patients are a lot more knowledgeable than some of the physicians out there at this time. And it's just the moment that we're in. And so hopefully these things are going to catch up. Hopefully we're going to actually have treatments to offer. And right now it's still a fairly specialized thing. And so I thought it was just important to make sure that we're all aware that there is a phenomenon that is happening wherein exercise is absolutely the wrong advice to give, and that we want healthcare providers, caregivers, and patients to be aware of that. Unfortunately, there's not a bunch of treatment at this point to prescribe, but the more we learn, the closer we get to that. So I did want to review this study that was conducted by Yale researchers and was just published in December. And it is kind of giving us some physiological explanations about what is driving the exercise intolerance in long COVID patients specifically. In this study, they looked at 55 patients. They were evaluated for post-COVID exercise intolerance. 41 of these patients had no evidence of heart or lung limitations on their initial testing. And so normally, if we were having someone that had exercise intolerance, we would be thinking, is this something cardiac? Is this something with, pulmonary? Is this something with the lungs? But 41 did not have any heart or lung limitations at all. Then they underwent a kind of an exercise test. It is a bit invasive, and this is not something that you're just going to be able to go to your doctor and get, unfortunately. So that's kind of the other thing that we're very hopeful that one day we'll have more studies where we can really assess people. But this is really more of sort of a research or more invasive kind of a test. And what they found is that the heart was pumping blood and providing adequate amounts of oxygen, but then the body was not really extracting the amount of oxygen to the tissues that was needed. So there was some kind of compromise where, although there was oxygenated blood pumping, the body's tissues were not able to extract the amount of oxygen needed. And so there was exercise intolerance. So I think this is important because it gives a physiologic basis, which is really important. So this is not something that, oh, you just feel tired or you're just stressed or you're just lazy. No, there's a physiological basis here for why there is exercise intolerance. And I'll just quote the lead author here, Dr. Peter Kahn. He's a pulmonary critical care at Yale. And he said, we found that the extraction of oxygen by the body's tissues was compromised in patients who had symptoms of exercise intolerance after COVID. And he also pointed to a benefit of this research, which was dispelling the potentially harmful myths that I spoke of earlier. He says our findings contradict that hypothesis and instead support the idea that there is a clear physiologic abnormality underpinning the symptoms experienced by our patients. So I think this is very important, and it leads into the next thing I wanted to share, which was a clip from that Senate hearing that we reviewed a couple of weeks ago. And we went over it in a lot of detail. But this time I wanted to share a clip from a patient who testified at the hearing, and her name is Angela Vasquez, MSW. She's a long COVID patient from Los Angeles, California. And she and another patient and a parent of a long COVID patient did an absolutely phenomenal job describing many of the challenges that they are facing with long COVID, everything from the symptoms they're having to navigating the healthcare system, the educational system, and all of the challenges that go along with that. So if you're interested, I did link it in the post. I suggest you take a look at that. But in this clip, Angela Vasquez was responding to one of the senator's questions, and it's a physician senator who was specifically asking about exercise and how exercise and physical therapy, asking wouldn't that be helpful, and has that been tried? And here is her response.
I will say that there's just so much evidence that post-exertional malaise is the downstream effect of exercise, and I think exercise and movement will improve when we manage the upstream drivers of post-exertional malaise.
Okay.
So I really thought that this was an excellent example of a patient being able to educate folks, dispel a myth in a very simple and straightforward way. And as you could hear, she got some applause from the crowd. But really, I think this is important from the standpoint of what it really means to do advocacy in this space of long COVID. And she described earlier how fortunate she is to have access to great care. And she's obviously doing quite a lot of reading and research and advocacy. And that in this moment is really what is needed. And it is much easier said than done. One of the concerns that has come up time and time again is that folks who are the most impacted by long COVID, who are very severe, who may not be able to even leave the house, let alone engage in different types of action and advocacy work, or clinical trials that their voice and their conditions may not be able to be really incorporated the way that we would like it to. And so for me, this really kind of represents how everyone has a role in this. Long COVID patients who are able to get out there and educate folks and speak directly, speak truth to power about what is going on. That is absolutely amazing. Patients who have ME/CFS and have suffered for way too long without attention on their disease, absolutely we need to hear from. The patients who may not be able to be fit enough or well enough to get out there and do some of these things can play different types of roles by staying connected, sharing their symptoms and what is going on. And we can advocate for them as well that they be able to be included in long COVID trials, either through telehealth or home visiting or some other way that we can incorporate some of the people who are the most impacted. Because that's really what it means to have an equity framework on how we are addressing challenges. If we're going to be equitable, then it's not about checking boxes. It is actually about doing everything we can to take the folks who are most likely to be marginalized, that are most likely to be left out of the conversation, and make sure that they get into the center of the conversation, that they're in the center of our consideration of how we are going to design trials, of how we are going to do advocacy. And this is difficult work. This is a difficult time as it relates to long COVID because of the sheer magnitude of illness that we are dealing with and all that we do not know. And we need all the things. We need more research. We need more trials. We need more treatments. We need more advocates. We need better understanding. We need more communication. We need more awareness. We need more prevention. We need a lot more prevention. And the only real way we know how to prevent long COVID is to prevent COVID in the first place. And so the main way to do that is to prevent transmission. And we know that that means better ventilation in our indoor spaces. It means high quality filtration masks. We also know that vaccination before you have long COVID reduces the risk of later getting long COVID. And every single time you get COVID is a new opportunity, not only for a bad outcome in the acute phase, but also is a new opportunity for long COVID. And we never know which time a person may get long COVID. You may be fine the first or second time, and then it could be on the third time. So we're hearing all combinations of this situation happening. And so being up to date on the vaccination does appear to be reducing the risk of getting long COVID. Now, it doesn't do necessarily anything for you after you have COVID. Some people it does help, some people it worsens, some people are unchanged. Still so much that we need to learn. And then understanding that long COVID is not one thing. There are a number of things going on, and there are subsets of patients. There may well be some subsets of patients that do improve with activity or with exercise. But until we really understand who that is, we cannot give a blanket recommendation that people with long COVID try to get out there and do some kind of increasing exercise, because that is actually advice that could end up doing harm. So we urgently need to figure out who is who and what is what when it relates to all of this. And we still do not have treatments that are proven to reduce the risk of long COVID, but there are a number of different trials going on. I talked about some in last week's briefing, but we know that outpatient treatment for SARS-CoV-2 can reduce the replication of that virus, and so that we're reducing the risk of a poor outcome. And as I mentioned, long COVID is more common in people who are hospitalized or go to the ICU or otherwise have a severe acute case of COVID. So I think for all of the reasons we know, we should be ensuring that people have timely access to outpatient SARS-CoV-2 treatment. And just a quick review, first line treatment of choice for most people is going to be Paxlovid. And unfortunately, this continues to be underprescribed. And as I mentioned, disparities in access to treatment are increasing, it appears. We know that there are medication interactions with Paxlovid, but most of them can be overcome by holding those other regular medications while on Paxlovid. So just something you need to work out with your physician. Remdesivir, also very effective, but unfortunately difficult to get. If you're someone that for some reason can't take Paxlovid, but you need to be treated, please get this planned out with your physician now. Maybe it will be with your specialist, with your rheumatologist, with whatever doctor is prescribing immunosuppressive medications and so on. But get this arranged ahead of time. It is outpatient, 3 days in a row IV treatment. And last line for most people is going to be molnupiravir. It is oral. It is, convenient, less, no real drug interactions, but it is significantly less effective against hospitalization and death than the first two, kind of like in the 30th percent reduction compared to 80-ish or so. But 30% is certainly better than zero. So this is an option to consider. And then for those who are immunocompromised, high titer convalescent plasma may be an option. Again, needs to be arranged. And these treatments, really most any antiviral treatment should be started sooner rather than later. And you can see the number of days window that you have there in the table. But in all cases, really, we should be making a treatment plan in advance. Do not wait to see how you feel. That is not how this works. We're wanting to prevent you from getting worse or going into that inflammatory phase of COVID that can land you in the hospital and that can affect really any organ in the body. But the main thing that we want to do is try to avoid getting infected and reinfected in the first place. Catching COVID once and doing fine is not a guarantee about the next time. And every infection is a new opportunity, perhaps even a compounded opportunity for long COVID and post-COVID impacts. So let's keep up those best practices to prevent the spread of COVID and other respiratory diseases also, but particularly COVID with all of the unknowns and all of the post-viral chronic illness that we are seeing. We're going to want to stay up to date on vaccination, wear a high quality filtration mask like an N95 or KN95 when you are indoors. If you can gather outside, that's almost always safer than inside. And when you're indoors, we want to make sure there's good ventilation and filtration, which you can monitor using a CO2 monitor and make adjustments to your indoor space based upon what you are seeing. And as usual, we'll want to just take good care of yourself in general. Remember to eat a balanced diet. Let's avoid those processed foods and sugary drinks. Get some regular physical activity unless you're sick. If you're sick, please get your rest, recover. And of course, unless you have long COVID, this is something that you're going to want to work on with your physician as to what your plan is going to be. And if you are someone who should be treated, if you get COVID, you should know that now. If you don't have a primary care provider, please get one. Do not wait until you need them to try to find them. That is not something fun to do when you don't feel well. Know how to reach them before you need them. And also go see them if it's been a while. Get your blood pressure checked, get your baseline labs checked, like your sugar and your cholesterol. And as usual, try to manage those stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us. We'll see you again next Tuesday at 10 a.m.